Good afternoon. My name is Dr. Christopher Tarnay, and I'm here to speak to you today on fibroid treatments. And I want to talk a little bit about an overview of fibroids in general and really focus in on some of the innovative treatments that we're doing here at UCLA, particularly ones that involve uterine-sparing methods. So if you'd like to join us, you can join us on Twitter with hashtag UCLAMDChat, UCLAMDChat, and look forward to you involving yourselves online. And if you have any questions, please feel free to tweet those along, and at the end of 30 minutes or so, I'll go ahead and get back to them, and we'll go over those questions with as much time as we have. So here's a fact. What % of American women have fibroids? It's 25%. So it's an extremely common condition that women suffer from. And so what are fibroids? Fibroids are non-cancerous, benign tumors that develop from the uterus, and they can remain very small, start the smallest size of an apple seed, for example, and they can grow really large, size of a grapefruit or even larger sometimes. And most women who get fibroids often have more than one. There's a lot of different names to fibroids. We can call them leiomyomas or myomas, or you even see them called fibromyomas. So there's lots of names, but fibroids in general is the most common one. And again, the critical thing is these are tumors of the uterus, benign, not cancerous, extremely common. And with fibroids, like real estate, it's all about location. So fibroids can grow into the wall. They can grow into the wall and push into the cavity. Or they can grow within the wall alone and not cause any problems. And it really depends on where they are in location will depend on the type of symptoms that patients have. They can even grow outside and push out into the abdominal cavity. So depending on where the fibroids grow and the size has a lot to do with the type of symptoms that they're going to cause. So who gets fibroids? Who's at increased risk? Fibroids are very common in women over 20 years of age. And as I mentioned, 1 in 5 women of childbearing age will have fibroids. And by the time they reach age 50, over half of women are going to have fibroids. In addition to age, other factors that increase the risk are family members that have fibroids, being of African American descent and even Asian descent, and being overweight. All may contribute to developing fibroids. Fibroids are a major cause of symptoms and visits to the doctor. And even today in this country, they're still the most common reason women are told that they need to undergo hysterectomy. So one of the real common questions that I often get in the office is, hey doc, if I have fibroids, will they continue to grow? And what I tell folks is most of the time, as long as you're in the reproductive years, they have the potential to get larger. And on average, fibroid growth tends to be slow, but can be up to about 9% change in volume or 9% change in size per half-year period of time. It appears to be related to race, as I mentioned. In white women, there's significantly lower growth rates than in women of African American descent. And as patients approach the menopause, African American women continue to grow at a fairly consistent rate, whereas you see in women of Caucasian descent, they tend to slow down. After the menopause, almost universally, fibroid size tend to reduce. And so as patients get near the menopause, if they're becoming symptomatic, we often try to do temporizing measures or non-surgical measures to get patients to the menopause so they don't have to do any interventions. All right, what are the causes of fibroids? Well, simple. Why they get them and why some grow more than others, we just don't know. The biology of fibroids is really interesting, and we're starting just at the cusp to understand from a genetic standpoint and from a biologic standpoint and from a growth factor standpoint what it is that's causing fibroids to grow. We're trying to identify whether they're dietary triggers or behavioral triggers or even environmental triggers that may be factors for this. Since fibroids grow rapidly, particularly when there's in a hormonal milieu, for example, during pregnancy, they can grow. And for example, when women get near the menopause, when the ovaries stop working and estrogen levels go down, fibroids stop growing. So certainly there's a major role for hormone therapy, and this plays a big factor when we talk about treatment and how to take care of women who have these conditions. As long as a woman is menstruating, a fibroid has the potential to continue to grow, and albeit slowly, But we do expect, as I mentioned before, a slow, steady growth rate for these in many cases. How are fibroids diagnosed? In most cases, it's during a pelvic examination. Your doctor, during your annual examination, will examine you and will identify something that feels like a fibroid, and this is often confirmed with a routine pelvic ultrasound. Ultrasound is often done in the office, or they can send you to a special radiological location. If there are instances where we're not sure of the location, particularly those fibroids that grow into the endometrial cavity, a special ultrasound called a hysterosonogram can be performed. Or a hysteroscopic surgery, a small camera into the uterus, may be needed to tell where the fibroid is. In situations where treatment planning is needed, an MRI is often preferred, and we're really starting to use MRI significantly because if we're looking for minimally invasive approaches, targeted approaches, having an MRI is the best roadmap for where these fibroids are, the size, and their location, and the blood flow. All right, so what are the common symptoms associated with fibroids? Well, bleeding symptoms, or what I call bulk symptoms. Bleeding symptoms are heavy, prolonged periods, bleeding between the periods, or painful periods. All could be due to fibroids. Now, certainly, there is a number of other causes, but anatomic causes such as fibroids can certainly contribute to these set of symptoms. Bulk symptoms feel like the abdomen is enlarged, feel something there in the stomach, can't quite get the pants to fit as well as they used to. Certainly, weight has to be a consideration, but if it's firm and particularly cyclically changes, like changes or gets larger with the menstrual cycle, fibroids could be a certain player. Patients will describe abdominal fullness or heaviness. And then there's the effect on the organs around the uterus. The bladder lives very close to the uterus. The rectum lives very close to the uterus. And when the fibroids grow and start to push out away from the uterus and into the adjoining organs, symptoms related to those organs may be involved. So pushing on the bladder, hey, you have to go frequently, urgency, frequency of urination. Pushing backwards toward the rectum, constipation, difficulty with elimination. And then the always ever concern of infertility. Fibroids, particularly cavitary fibroids, but even fibroids that grow in the wall, all may have a negative impact on one's ability to conceive. What are some of the complications that can occur with fibroids? Well, fibroids that are attached to the uterus by a stem may twist and cause pain. These are called pedunculated fibroids. When they twist and cause pain, they can cause ischemia or poor blood flow to that area and cause nausea or even fever. Fibroids that have a real rapid growth rate can actually grow so fast that they outstrip their blood supply and they can start to degenerate on the inside. We call these degenerating fibroids, and these can cause pain. They elucidate lots of inflammatory factors, cytokines that get into the bloodstream and cause a lot of pain, particularly cramping pain. So rapidly growing fibroids can outstrip their blood supply. Rarely fibroids are related to cancer, and we'll talk a little bit about that at the tail end of the discussion. This is an image of all the different places that a fibroid might grow. In instances, we've had patients who have fibroids in every single location, so they can be growing into the cavity. We call those submucous myomas or fibroids. They can grow from the wall outside, like I showed you earlier. We call them subserosal fibroids. They can grow in the wall, intramural. They can grow into the cavity and intracavitary. Or these ones that grow on the outside, the ones with the stem that we were just talking about and that can twist like a tomato on the vine. These are called pedunculated myomas. And again, they can be small and cause symptoms, like this one here, or they can grow large and cause symptoms like bulk symptoms, like these subserosal or pedunculated fibroids. A very large fibroid can cause swelling in the abdomen and can really make a pelvic exam very hard to complete. And this is a case where, for example, the doctor would say, listen, we need to send you to and get an ultrasound or an MRI to help evaluate further. All right, so can fibroids cause fertility problems? Fibroids can certainly cause infertility, although there are many other causes that are even more common. And there are certainly many instances where patients have fibroids and go on to conceive and have normal, healthy pregnancies all the way to term. And certainly other factors should be explored before fibroids are blamed as the primary cause of infertility. So we usually have to exclude all other causes before we start blaming those fibroids for a reason that a patient may have trouble getting pregnant or for staying pregnant. Fibroids that grow inside the cavity, those intracavitary fibroids, are really common in women with infertility. And importantly, women are able to become pregnant after they're treated. So if you can remove that fibroid that's contributing to the infertility, you take it out with a hysteroscopic procedure or a myomectomy, then patients have a real high rate of conception afterwards. All right, so that's a little bit about fibroids. Let's talk about treatment options. So there's a battery of treatment options, and here at UCLA, we have a very firm dedication to offering multimodal treatments. We have a fibroid treatment center with radiologists and surgeons and medical specialists, and all of us are vested in trying to find the right approach and right treatment that's tailored to fit that patient. So we have medical treatments. We have what I call external-based treatments, things like endometrial ablation, uterine fibroid embolization. There's minimally invasive surgical options, radiofrequency ablation, laparoscopic myomectomy, and then the use of the robot to help us do a laparoscopic myomectomy. And then in instances where the fibroids are large or too numerous, open surgery, which is a large incision like a bikini incision or a C-section or cesarean section style incision. And this is when we do a myomectomy or a hysterectomy. If one is considering medications, because fibroids are so hormonally sensitive, we often use hormonal therapies to help combat symptoms. And particularly when there's bleeding as an issue, birth control and other types of hormonal birth control methods are often used to control the heavy bleeding and painful periods. It can be exceedingly effective, working over 50% of the time. Not 100, but at least half the time. There's medications called gonadotropin-releasing hormone agonists, or the trade name is Depo-Lupron. And this is an injection-style medicine. And this medicine works by acting at the level of the brain to tell the ovaries to stop making hormones. When the brain gives the signals to the ovary to stop making hormones, the fibroids then shrink up. There are side effects related to the agonists. Most specifically, it creates a medical menopause. So it temporarily creates menopausal state. So patients sometimes have hot flashes. It also can have an impact on bone and bone loss that's reversible after the medication, but it's something that we always take into consideration, particularly if we're considering extending the use of the treatment. It can be very effective in helping women who have very heavy, painful periods. We give them the Lupron and the periods stop. If there's heavy bleeding that's contributing to anemia, we can then start working on therapies to correct the anemia, like giving them iron, and patients start to feel better. So this can be an excellent measure to help us care for women with fibroids, particularly in the acute setting. We also use these GnRH agonists to help shrink fibroids. If fibroids are exceedingly large, we can shrink them down and they have less bulk symptoms. We can also shrink them down so that where in one instance where we might have to make a large incision, we can shrink them down and then make that patient a candidate for a minimally invasive option like a laparoscopic procedure. So this is a very nice tool in our tool belt that we can use to treat fibroids. The problem with using these agonists is after we stop the therapy, the fibroids can go back to their original size, or because the hormone starts to ramp up again and start stimulating those hormones, fibroids. There's something called progestin-releasing intrauterine device. This is like an IUD, but it has a hormone in it, and that hormone is a very effective way of tricking the endometrium, or the lining of the uterus, to not grow. And so if a fibroid is contributing to bleeding problems, we can actually attack it at the level of the endometrial growth so that we don't see the manifestation of that fibroid, which is heavy bleeding. So this progestin insert, the trade name is called Mirena, M-I-R-E-N-A. It's a good option for women with fibroids that don't have a lot of endometrial cavity distortion because it reduces heavy and painful period, but it doesn't treat the fibroids themselves. So it's better for patients who have bleeding symptoms, not so much bulk symptoms. But this can be left in for 5 years at a time, and for a woman who's, for example, 47 and she's knocking on the door of menopause, doing a Mirena intrauterine device, or even Lupron, the GnRH agonists, are really nice ways to bridge patients to the menopause and then her body will take care of this problem naturally. So we were talking about some of the other options. Myomectomy is a surgical option. This is a common alternative to hysterectomy. And what myomectomy means is surgical removal of the fibroid tumors. And it is the standard of care of how we take care of these fibroids, particularly when we're interested in preserving the uterus, which is what we'd like to do in all instances where women, of course, are considering fertility or are not yet family complete. It's the most common option recommended for women who wish to become pregnant. When the fibroid is in the cavity and small, we can do a hysteroscopy for small fibroids that bulge into the cavity, and even fibroids up to 3, even 4 centimeters can be managed this way. For larger fibroids or ones in the wall, we have to attack it from the outside with a laparoscope. And this is a preferred method over open surgery unless the fibroids are too large or too numerous. So this is just a picture of what a uterus looks like with a bunch of subserosal or fibroids that are growing from the wall to the outside. So here is the uterus, and here are the fibroids growing outside of the uterus. There's at least 4 in this picture, and they can grow as big as a lemon or an apricot or a grape. This is an extremely advanced case of fibroids where this young woman had a number of fibroids growing off the uterus. It looked like a sack of potatoes. And she had been living with this for a long period of time, and she had both bulk and bulge symptoms. And we were able to pull each of these fibroids off and reconstruct her uterus, and she went on to get pregnant. So let's talk a little bit more about hysteroscopic myomectomy. Here's just a cartoon picture of what it looks like. This is a procedure that's done in the operating room. It can be what we call a same-day surgery. You come in the morning and you go home the same day. And we can insert a hysteroscope, and it has this little loop, we call it the resectoscope, and it's got this little loop, and we can shave this fibroid. So this is a fibroid in the cavity. It's causing bleeding symptoms, or maybe this patient's trying to get pregnant and can't do so because this fibroid's in the way, causing an abnormal environment for implantation. We can remove the fibroid. The patient goes home the same day. As soon as she heals, she can go on to try to conceive. It can be done under a local, but typically with sedation. Got excellent to good success rates and high fertility rates and very low rates of complications such as uterine rupture. We've got endometrial ablation. This is another minimal surgery where we can take the patient to the operating room, insert an instrument which either puts in hot water that actually burns the lining, or a coil which heats up the uterine lining. And if a patient has fibroids that's causing irregular bleeding, the lining can be burned or thermally necrosed in order to treat the bleeding. Now, this is not a procedure that we would use in a patient who's desiring fertility, but in a patient, for example, who's 46, 47, 48, near the menopause, is tired of the bleeding. This can be done in patients who don't have large fibroids that distort the cavity. What about laparoscopic myomectomy? This is a minimally invasive procedure, preserves the uterus, and instead of making that large incision, we can make small incisions and put a camera in and then instruments and resect the fibroids. There's lots of advantages of a laparoscopic myomectomy over an abdominal myomectomy. There's less pain, less need for blood transfusion, shorter hospital stay, faster recovery, quicker return to activity, and less scarring because we have to make small incisions versus a large incision. When we have a very challenging fibroid or many fibroids, sometimes it's really helpful to add the robot to the mix. And that is a tool that helps us as surgeons do a minimally invasive surgery. So we still do laparoscopy, but we apply a robot to that and we operate the robot. This has specialized instruments, specialized high-definition three-dimensional viewing. It allows us to visualize the fibroids, get right close to where we need to be, and use these instruments to do precise dissection and suturing. And there's different tools that we can use to help facilitate this so we can avoid a large incision and preserve the uterus. This is a picture of a large fibroid that goes almost all the way up to the belly button in a patient. And this is her uterus here, and you can see that it's hanging off of the top of the uterus. and this large 10-centimeter fibroid. And this is a patient who would be an excellent candidate for a laparoscopic or robotic laparoscopic myomectomy. Don't need that big incision. You can just do it laparoscopically and remove it. As I mentioned, robotic laparoscopy is another tool that allows more women to avoid that large incision, and we can do a minimally invasive uterine-sparing surgery. It's also a short hospitalization. Again, easy return to work, easy return back to activity, less pain, and good cosmetic effect. This is the patient table. We have this robotic platform that moves right into it, and then the surgeon sits here and we can operate on the console. Another very exciting modality that's relatively new, and UCLA is on the cutting edge of leading this charge, is a technique called radiofrequency ablation, or RFA. This is another procedure that's designed to thermally damage the fibroid, but not damage the surrounding structures. So it's a laparoscopic procedure in which we apply a special instrument and a needle that goes into the fibroid, and we use real-time ultrasound. We put a little ultrasound probe right next to the uterus during laparoscopic surgery to identify the fibroid. The needle goes in, we use ultrasound to direct the radiofrequency energy, and this shrinks the fibroid. And we can target very specifically where we're applying that energy with the use of real-time ultrasound. It's really good for women who want to preserve fertility and want uterine-sparing treatment. When applied, we've got 12-month data showing 50% reduction in symptoms and 45% reduction in size for patients that respond. This can be done for fibroids up to 4, even 5 centimeters, even up to 10 centimeters in some situations, and it can be done with even multiple fibroids. So this is exciting new technology, allows uterine-sparing procedure in a minimally invasive fashion. Other therapies that don't involve surgery, but these are these external treatments, something called uterine artery embolization, or UAE, or uterine fibroid embolization. It goes by both names. This is generally done by radiologists, and there are many radiologic centers that are focusing just on this treatment only. We have it a part of our entire comprehensive treatment program, and it can be very effective for patients who aren't surgical candidates or who patients don't want surgery and still want to retain their uterus. In general, this is not a good procedure, and we don't recommend it in patients who wish to preserve their fertility, because it acts by accessing the blood supply to the uterus. Catheters are placed in the groin and fed up under radiologic visualization into and toward the uterine artery. There we use small gel or small particles to block the blood flow. So we identify the fibroid, usually with an MRI, and then find those blood vessels that feed the fibroid and specifically target those for blood flow constriction by placing the gel or the particles into the blood vessel. There's a long history of use with this, and it's very effective. Catheter is placed under guidance. We infuse the gel or the small particles. It causes ischemia by cramping off the blood supply to the fibroids. Average procedure time is about an hour, and in studies we see up to a 60% reduction in volume, and we also see a change in the consistency. Fibroids are these rubbery, firm tumors, and after uterine artery embolization, they turn kind of soft and mushy. So when someone's had some symptoms of pushing on another organ or pushing out to the abdominal wall, by changing not only the size, but the character and the consistency of it, patients have less symptoms, and we see excellent reduction in symptoms. When you look long-term, about a 20% chance that one might need another procedure, like perhaps another uterine artery embolization, or if the fibroids continue to grow, they might ultimately end up needing a surgery. So it's a good therapy, not perfect, because 20% of the time it might need something else. Here's another very exciting therapy. Again, we here at UCLA are leading the way of this, and we have one of the few procedure rooms and machines that can allow us to do this. It's called magnetic resonance guided focused ultrasound. We call it HIFU for short, or high focused ultrasound. This is a non-surgical therapy. There's no cutting, no need for incisions. A patient sits in a MRI tube, and a small amount of ultrasound waves are sent through the abdominal wall into the fibroid. and causes coagulation or thermal necrosis, causing that fibroid to shrink down. No surgery, no incision, and minimal downtime. The procedures can be done on patients who have fibroids up to 7, 8, even 9 centimeters, and even patients who have multiple fibroids. And we've used this with great success to help patients who want to avoid surgery and want to preserve the uterus. And the really interesting thing about this therapy is that we feel that because it's so targeted, patients can go ahead and try, and we can do this on patients who still want to maintain their fertility. So it's a radiologic procedure. It can be done for patients who want uterine-sparing procedure, who want to maintain their fertility prospects, and it can be done without incision. It's used for medium-sized fibroids and can reduce both symptoms of patients who have bulk symptoms and bleeding symptoms. I think we have a link to a YouTube video that shows a cartoon animation of that procedure that we'll be tweeting out. All right. Here's another question that we often get, particularly as we talk about medical management. Does taking birth control pill cause my fibroids to get bigger? Well, this is where we have a lot of data that's conflicting. But in general, taking birth control pills do not cause fibroids to grow. If you take 100 women, you give them birth control pills, you'll see patients mostly act like patients who are on birth control pills at all. So you'll see some patients grow, some patients stay the same, some patients will actually have shrinkage, and that's what we see typically. There's a lot of information indicating that the pill does not stimulate the fibroids to get bigger, and in fact, women who use the pill who have fibroids actually can be very helpful because, as I mentioned, it can reduce blood flow, reduce the risk of anemia, reduce the risk of downtime and pain, and even irregular spotting between menstrual cycles. All right. Again, if you have any questions, feel free to tweet us at UCLAMDChat. All right, a lot of the questions that come into the office of patients are often wondering, well, listen, I've got some symptoms. What's normal? What's not normal? What can be due to fibroids? What may not be due to the fibroids? So this slide just kind of goes over some of the real common symptoms that often get attributed to fibroids. How about pelvic and menstrual pain? Well, it's pretty normal and physiologic to have mild to moderate pain before or during the periods. However, if that extreme pain is bad enough where it's interfering in your life or work, certainly further investigations and bringing this up to your doctor may prompt them to evaluate you for fibroids. Bleeding, typical normal, is mild to moderate, 4 to 6 days once a month. If periods that last longer or heavy, where you're requiring lots of pad usage or tampon use, or regular breakthrough bleeding, this again is a real good reason to go to your doctor and find out, again, if fibroids could be contributing to your bleeding. Painful intercourse shouldn't be painful. Certainly, patients who have pain would deserve an evaluation and to look for an anatomic cause. Back pain, really common, and fibroids get blamed for a lot, even back pain. But if the fibroids are in the back, posterior in the wall, and pushing backward and large, certainly back pain can be a player for patients who have fibroids, particularly if the back pain is cyclic. Hey, this gets really bad at the time of my menstrual cycle. Then you want to be looking for an anatomic cause that may be contributing. Chronic headaches, typically one would see this only in instances due to fibroids, due to heavy bleeding. And then infertility. Absolutely, if patients are struggling with conception and haven't had spontaneous conception with regular intercourse over the course of a year, that would absolutely deserve a workup. All right. So, this is a summary slide about different types of surgical options. When we talk about external treatments, like uterine artery embolization and high-focus ultrasound, no incision, typically less pain, typically low risk of complications because there aren't any surgical interventions, little to almost no blood loss. It's an outpatient procedure. Come in the morning, go home later that day. Quick recovery, but as I mentioned, symptoms can sometimes recur. We talk about open surgery, like an open myomectomy or an open hysterectomy. Long cut, usually like a bikini cut or C-section incision, sometimes even a midline incision. It can be painful. There's risk of complications as with any surgery. Blood loss can be significant. Hospitalization days, up to 6 days for some. Long recovery. With laparoscopic surgery, robotic surgery, small incision, less pain, less complications. Blood loss typically lower than an open surgery. short hospitalization, say, and quicker recovery. Well, I hope that answers some questions you might have had about fibroids, or if you didn't have questions, it's taught you a little bit about what they are, what some of the common questions that come into the office that we try to help treat. And if you had any questions, feel free to tweet those, and I think I'm ready to take those now. Okay, so I got my iPad here. Do I ever see cases of endometriosis and fibroids? I've been trying to get pregnant for a long time, and how common are fibroids in women in their 20s? Oh, these are all different questions, I beg your pardon. All right, so let's just take it one at a time. Do you ever see cases of endometriosis and fibroids? Absolutely. Literally, an hour ago, the last patient I saw before I came over here today was a patient who presented with just that. She had pain, she had painful periods, she had a large mass on ultrasound and MRI that was a subserosal fibroid. I didn't know she had endometriosis. I thought everything was due to the fibroid. I got in, she had a large fibroid which I took out, but concurrently she had fibroids in the background. So these are two different conditions. Endometriosis is when there are small implants from the endometrial lining that gets outside of the endometrial cavity. And endometriosis is a really common cause of pelvic pain in patients. It can cause pain during periods, it can cause painful urination, it can even cause painful intercourse. And patients with endometriosis also have a harder time getting pregnant. So there are two different entities, endometriosis and fibroids, but they're both common and they can certainly both coexist at the same time. All right, the next question. I've been trying to get pregnant for a long time. How common are fibroids in women in their 20s? Well, earlier on in the slideshow, I mentioned that women of reproductive age, fibroids are exceedingly common. If we just screen young women, up to 1 in 5, even up to 1 in 4 is going to have evidence of fibroids. And even as patients get older, we still see evidence of fibroids well after the menopause, although most of them are physiologically inactive. So fibroids are common in about 20-25% of women in their 20s. All right, the next question. What are some complications and risks of laparoscopic myomectomy in someone who is battling cervical cancer? All right, well, this is a really, I think, challenging question because certainly patients who are dealing with cervical cancer or truly invasive cancer, those patients often have already had a hysterectomy to help diagnose that. And patients who have an ongoing cervical cancer that's too advanced, fibroids would be literally the least of the concern. Maybe a more common question that I get is patients who have cervical dysplasia or they have precancer or even a high-grade lesion that they're being followed by their doctor. And so if one has a cervical dysplasia and fibroids, that would actually be a conversation a very individualized conversation because that would really depend very much on what that woman is planning to do with her uterus. If she's young, she hasn't had children yet, everything we would do to preserve her fertility options would be at the highest priority. So it would be management of the cervical dysplasia and to help her get pregnant, management of her fibroids, and certainly she'd be a fine candidate to undergo a laparoscopic myomectomy. And this is patients who have dysplasia. True cancer, that patient's going to get a hysterectomy with her cervix removed because that's going to be the safest thing for her. Okay, here's another question. It's an interesting one, and one I also hear a lot. Is there any connection between breast cancer and fibroids? A lot of times patients will come and say, I have fibromas in my breast, and I have fibroids in my uterus. And because the words are very similar, in fact, and frankly, some of the histology is very similar, some women think that they're related. The fibroids that grow in the uterus are completely different than breast tissue. And there isn't any link to breast cancer and fibroids. Fibroids are benign and are completely separate from women who may be experiencing or suffering breast cancer. All right, one more question. What are some similar conditions to fibroids that happens in other parts of the body? Well, we kind of just talked a little bit about that. There are breast fibromas, and fibroids generally are isolated to the uterus, although there have been instances, and we've had cases where fibroids can be what we call parasitic and leave the uterus and grow in other places. We've had fibroids grow near the intestinal tract, fibroids grow near the kidneys, fibroids grow in the bladder, or even in the vaginal area. And these are likely due to fibroids that start off as pedunculated and then grab their blood supply from another adjoining area, and then that stalk separates from the uterus, and then they find a home somewhere else, but generally in the pelvis. Very rarely do we see metastatic presence of fibroids in any other place. And again, there are certainly other instances of what we call connective or stromal tissue type tumors in other areas of the body that have similarities to fibroids, but fibroids themselves are a muscular tumor and don't occur in other places of the body. The next question is, when should I be concerned about menstrual cramping? Well, that's, I think, maybe, let's go back to that slide of what's normal and what's not normal. So again, bleeding, mild to moderate, 4 to 6 days a month with some mild cramping is certainly normal. Heavy periods, heavy cramping, all those would prompt you to visit with your doctor and for that doctor to look for other types of causes, one of which could be a fibroid. But certainly women who have heavy menstrual cycles and heavy painful menstrual cycles may not have any fibroids at all, and that could be simply a function of her physiology. And that could be also effectively managed. Okay, I like this one. If I stop taking birth control, will my fibroids return with a vengeance? Well, that's another good question. If one has had fibroids and symptoms of fibroids, particularly the bleeding, and your doctor has decided to put you on birth control, certainly the cessation or stopping birth control, for example, if one is trying to start a family, the prospect of that menstrual cycle coming back with a vengeance is certainly possible. These are the instances where I tell a patient, listen, the only way you're going to get pregnant is if we take you off the birth control, so you're going to have to ride out those horrible menstrual pains and heavy periods with the benefit of getting pregnant. And certainly as soon as one gets pregnant, the menstrual cycle stops and problem solved, at least for 9 months. So that's all the questions I have from Matt. Anything else come up on the Twitter feed? Okay. All right, that's all I have for you today. I appreciate you guys tuning in, and certainly continue to stay with us on the Twitter feed for UCLA, and